This is a presentation on the quality caring model based off of a middle range nursing theory prepared for the Graduate School of Nursing at the University of Hartford, presented by Robin Sis. Today's thesis statement is as followed. While many nursing theories have been developed to offer insight into the art of caring, Joanne Duffy's quality care model is unique because of its strong connection between caring relationships and behaviors, which leads to self-advancement and positive patient outcomes. The objectives for this presentation are as followed. Provide a brief background on the nursing theorist Joanne Duffy. Explain the quality care model and review the model's theoretical frameworks. Next, we will summarize the nursing meta-paradigm related to the quality care model and analyze the model's strengths and weaknesses. Lastly, we will review how this model is applied to current-day practice on a cardiac and vascular surgical floor through the use of one case study. First, I would like to give some background information on nursing theorist and creator of the quality caring model, Joanne Duffy. She graduated from St. Joseph's Hospital School of Nursing. She then went on to receive her BSN from Salve Regina College in Rhode Island. She completed her master's and doctoral degrees from the Catholic University of America. After graduating, she held staff nursing positions in critical care and emergency room services. From there, she became the director of 2 urban hospitals and is known for directing 5 nursing graduate programs. Like many theorists, Joanne Duffy is affiliated with many nursing organizations with leadership titles. As a scholar, Joanne Duffy continues to teach research, theory, and leadership within graduate programs. Currently, she is the Executive Vice President and Senior Consultant at QualiCare in Winchester, Virginia, and also an adjunct professor at the University of Indiana School of Nursing. The art of caring is fundamental to nursing. Nursing involves more than task completion. It is also about attending to the biopsychosocial, cultural, and spiritual needs of a patient. Yes, it is true that nursing tasks and interventions save lives and produce positive patient outcomes. However, how about the caring component? Do caring-specific interventions also help increase the quality of care and fuel positive patient outcomes? This is the very question and idea that nursing theorist Joanne Duffy devoted so much of her time and work towards. I'd like to discuss the development of the quality care model. This model was developed in response to the 1980s nursing literature, which highlighted a trend that patients did not feel cared for, which impacted their perception of quality outcomes. Joanne Duffy created the quality care model in response to this situation. In 2003, the quality care model was initiated and developed. Its major concept is caring relationships and its impact on quality of care. The purpose of this theory is to guide professional practice and explain the connection between quality of care and human caring. The goal is to generate a theory that leads the way in creating care-based interventions which can be measured. Now I'd like to talk about the nursing meta-paradigm within this nursing theory. There are 4 major concepts: humans and relationships, relationship-centered professional encounters, feeling cared for, and self-advancing. Humans and relationships acknowledge the fact that humans are social beings and their connections to others help them contribute to themselves and the communities. Relationship-centered professional encounters addresses the nurse-patient relationship and the caring interventions that influence this relationship. Feeling cared for. This is a positive emotion outcome that a patient experiences when caring relationships and behaviors are developed and put forth into the relationship. It gives patients the ability to become active within their own healthcare. The last step is self-advancing. Feeling cared for triggers self-advancing. This concept takes time and is an ongoing process, and it is catalyzed by caring connections and interventions. Like most nursing theories, there are assumptions and propositions. Joanne Duffy's nursing theory states that humans live in relationship to themselves, others, environment, and communities, and that humans are capable of adapting, growth, and change. And nursing work is done in the settings of human relationships. Caring relationships benefit both the nurse and patient. Remembering to care for oneself strengthens the care that nurses give to others. Caring is a concept that is accessible. Caring relationships do fuel the feeling of being cared for. This sense of being cared for initiates self-advancement. Caring relationships and caring behaviors are two essential factors that affect the core relationship. The core relationship in this situation is the nurse and the patient. The nurse must develop 4 important relationships that will positively impact the core relationship, the relationship with their patient. That is self, patient family, healthcare team, and communities. Self-relationship occurs when a nurse places value on self-care. Oftentimes, nurses care for more than just their patients, children, parents, families, and friends, and forget to connect with themselves. Regular mindfulness, such as exercise, meditation, nutrition, helps reduce stress and promote self-awareness. During work, consistent short pauses or deep breathing help nurses focus and center on the person they are caring for at that particular moment. It is vital that the nurse creates and maintains a relationship with their patient and family. This takes time, intention, skill, and knowledge. Caring behaviors and interventions directly affect the patient and family relationship. It is necessary for nurses to develop a working relationship with their healthcare team. Working collaboratively is essential to the quality of care and patient outcomes. Communities. Developing relationships within a community can enhance a nurse's sense of belonging. Now I'd like to discuss the caring behaviors that impact the core relationship with a patient. Mutual problem solving. This helps families participate in their care, learn about their illness, and this behavior also recognizes that the patient and family are the decision makers of their own care. Attentive reassurance. This is the ability to remain focused and centered on a particular patient and to be focused on individual needs and to actively listen to patients. Encouraging manner. Using a supportive manner during care and interactions, making sure that your body language matches what is verbally being said. Appreciation of unique meaning. Making sure the patient feels understood, and the nurse uses this behavior to clarify what is significant to the patient and tries to understand things from the patient's perspective. Healing environments. Maintaining a surrounding that is conducive to healing is a priority, reducing stimuli whenever possible. Affiliation needs. Being aware of affiliation needs means the nurse realizes how important social contacts are to patients, and the nurse promotes and makes time and creates access to family and friends for patients. Basic human needs. The nurse understands that basic human needs and addressing them are a top priority for patients to heal. Human respect. This is valuing the entire human person, performing tasks in a gentle, genuine way. This is a picture of the theoretical framework of the quality care model. It demonstrates the interplay between caring relationships caring behaviors, strengthening the caring core relationship. Caring relationships, self, community, patient, family, and healthcare team are always interacting with caring behaviors. The goal is to strengthen the core relationship, have the patient feel cared for, which then moves them into self-advancement and promotes health, healing, and positive outcomes. I would now like to go over the implications of this quality care model on current nursing practice in an acute care setting. The quality care model has strengths and weaknesses. Some of the strengths are as followed. Caring is fundamental to nursing. Everything that nurses do is usually done with care. This model places emphasis on the nurse's self-care. When nurses take care of themselves, they're more apt to give better care to others. This model describes the link between caring science and improved quality of care. Patients should always be the decision makers in their care, and this care model does support that. Caring science improves interpersonal practice, meaning nurses who are able to give the care that they want to patients feel better about themselves. Their cup is filled as well. Most nurses truly want to care for their patients by addressing their entire being. This model also can be applied in a few different healthcare settings, like both acute care and long-term care. Some weaknesses of this model are the time constraints that nurses face in an acute care setting for them to take time to recharge. The importance of self-care is not discussed at any type of skills or nursing validations. Oftentimes, developing a meaningful relationship is difficult in a shorter admission than it is in a longer length of stay in the hospital. Current patient assignments leave nurses feeling overwhelmed, therefore caring behaviors might get missed or overlooked. As Joanne Duffy points out, there is a lack of research regarding measuring a patient's perception of caring behaviors. This can in return negatively affect their perception of quality of care. I would now like to go over a case study. Mr. Sullivan is a 58-year-old man who is admitted to the hospital for chest pain. He has a past medical history of anxiety, non-insulin dependent diabetes, and hypertension. Upon Mr. Sullivan's arrival to the hospital via ambulance, it was noticed that he had EKG changes. Mr. Sullivan was suffering from ST elevation myocardial infarction. He was rushed to the cardiac catheterization lab, where they were unable to place a stent. Therefore, Mr. Sullivan was rushed to the operating room, where he received an emerging coronary artery bypass grafting surgery. Mr. Sullivan was post-operative day 1 when he was transferred from the cardiac ICU to the post-operative cardiac surgery floor. Amanda, the nurse accepting Mr. Sullivan, received a thorough report. Before Mr. Sullivan arrived to the unit, Amanda gave report to the patient's nursing assistant, Martha. During report, Amanda was told that the patient had pain control issues related to his chest tubes and was refusing to take any pain medications. Mr. Sullivan arrived at the unit. Amanda greeted him in his new room. She immediately asked Mr. Sullivan what his preferred pronouns were and what name she should write on the patient's whiteboard. The room was previously set up with bed sheets turned down, water pitcher full, and shades pulled halfway up to allow for some natural light through the window. Amanda and Martha helped Mr. Sullivan into bed. He seemed very guarded and moaned in pain. Once the patient was settled and assessed, Amanda asked if he would like any pain medication. Mr. Sullivan explained to Amanda that he had wished to only take pain medication if it were necessary or if the pain became unbearable. Amanda intently sat next to Mr. Sullivan, made good eye contact with him, and began to ask questions in a non-judgmental manner related to his rationale for not taking pain medications. Amanda found out that Mr. Sullivan's brother passed away from a drug overdose about 10 years ago and swore he would never take pain medication in his life. Amanda sat with Mr. Sullivan in a very supportive manner, acknowledged his fears, and offered her condolences. She then began to give education around the topic very sincerely. She mentioned that he endured an emergent surgery and a traumatic experience. Mr. Sullivan seemed very open to discussing the possibility of taking pain medications. Amanda educated Mr. Sullivan on the facts and myths about taking pain medications postoperatively. After they chatted for about 15 minutes, Amanda told Mr. Sullivan that he did not have to make a decision at this moment, and if he wished to do so, she would be available anytime to get him more comfortable with the help of pharmaceuticals. She also suggested talking over this decision with his partner and/or children if they thought that would be helpful. Before she left the room, she made sure his urinal and call bell were within reach. Amanda also adjusted his pillows and asked if there was anything else she could do for him. Mr. Sullivan answered no and thanked her for taking the time to listen to his story. Amanda replied, "It was my pleasure to listen and help. I will see you in about an hour during hourly rounding, if not sooner." During afternoon rounds, Amanda gave Mr. Sullivan his first dose of pain medication with very good effect. At lunch, Amanda went for a walk with a coworker to get some fresh air, and then rested in the unit's tranquility room for 10 minutes to engage in centering herself before heading back onto the unit. Amanda made a point to discuss Mr. Sullivan's concerns with the team and passed this information along in nursing report. In this case study, the RN Amanda used self-care throughout her day, making time for herself, connecting with herself, and recharging. She also created caring relationships. She did this with her patient and her colleagues. An example of a caring relationship with her colleagues was making sure that she informed her colleagues about her patient's concern about taking pain medicine. She also carved time out in her day to take a walk with a colleague. She also mobilized nursing knowledge and facilitated growth. She integrated caring relationships with evidence-based practice and research. She sat next to her patient, actively listened, and focused only on him, and then offered evidence-based solutions to help him make a decision. Nurse Amanda used caring behaviors and caring interventions to help guide her practice. Human respect. The nurse and nursing assistant greeted the patient as they arrived. They also asked about the patient's preferred pronouns and made eye contact when speaking with the patient. They created a healing environment. The room was ready when the patient arrived. It was uncluttered and filled with natural light as opposed to fluorescent lighting. They appreciated the patient's unique needs. Nurse Amanda was able to vision things from the patient's perspective. She acknowledged what was important to the patient in reference to pain management. She was encouraging as she used a supportive tone and displayed nonverbal supporting cues. She mutually problem-solved with the patient. She promoted patient learning, and she recognized that the patient is the decision maker in this circumstance. She responded to attentive reassurance by listening intently. She purposefully made the patient feel secure when she stated she'd be back for hourly rounding. She gave the patient her undivided attention. Affiliation needs. The nurse honored and encouraged family involvement. Nurse Amanda addressed basic human needs as she made sure that the patient had his urinal and call bell before exiting the room. She also adjusted the patient for comfort. In conclusion, we have gone over Joanne Duffy's nursing theory. We have discussed her quality care model, and we've identified her theoretical framework and as it applies to nursing practice today. Her theory and quality care model places emphasis on self-care. I find this to be very important for nurses to do, especially in today's world of nursing. Thank you.